It's my pleasure to welcome you again to the annual interdisciplinary lecture series entitled Advocacy in Healthcare and Medicine. Today, it's a real pleasure to introduce one of our former faculty members, a good friend and a real leader in the world of biomedical ethics, Dr. Dan Sulmasy. Before I introduce Dan, I do want to just remind you that next week, March 5th, we will hear from Dr. Carl Griffin Trotter of St. Louis University, and there's a full list of speakers on the brochure, which you could pick up on your way out if you would like a hard copy. So let me go ahead and briefly introduce Dr. Sulmasy. He is the Andre Helligers Professor of Biomedical Ethics in the Departments of Medicine and Philosophy, and also serves as the Director of the Kennedy Institute of Ethics and as a faculty member of the Pellegrino Center for Clinical Bioethics at Georgetown University. Dan received his AB and MD degrees from Cornell University, trained in internal medicine at Johns Hopkins. He has a PhD in philosophy from Georgetown. He has served on numerous governmental advisory committees, including the Presidential Commission for the Study of Bioethical Issues from 2010 to 2017. Dan is a practicing internist and a philosopher. He is the editor of the journal Theoretical Medicine and Bioethics. He has written really extensively on lots of topics in bioethics, especially regarding care at the end of life. He has 7 books, including Methods in Medical Ethics, The Rebirth of the Clinic, and physician-assisted suicide and euthanasia before, during, and after the Holocaust. And Dan was a colleague here at the MacLean Center for a number of years, and it's really a pleasure for me to welcome him back. So thank you, Dan.
Well, thank you, Peter, for that very kind introduction. It is good to be back here with so many friends and colleagues, I wanted to begin, however, on a sad note. I don't know, any of you who know anything about ethics probably know the Georgetown mantra of autonomy, beneficence, non-maleficence, and justice. And the premier author of that, Principles of Biomedical Ethics, Tom Beecham, our distinguished colleague and friend at the Kennedy Institute, just passed away last week. So I wanted to take a chance to acknowledge his contributions to the field, to ask all of you, if you would, if you're interested in all in bioethics, to bow your heads with me in a moment of silence in remembering Tom and his contributions. Thank you all. Thank you, Tom, actually. Thank you, Tom. You have a series, I guess, about physician advocacy. This may seem like it fits in awkwardly, but I'm going to talk about unionization of physicians because it's often presented as a tool for advocacy, sometimes for patient care, but often for physician well-being. And we'll take a sort of deep historical dive to start with. I want to talk about the way in which medicine has been organized, at least in the West, over 2,500 years. Before Hippocrates, physicians were really peddlers of wares in the marketplace, just like cobblers or people who were selling pots. They were itinerant craftspeople who would basically share their services with anybody who came. And what the Hippocratic movement did was to take a small sect of healers, who were mostly a religious group, the Asclepiads, combine that with the new sort of empirical science of its day, empiricism in medicine, and give it this sort of moral purpose via the oath. And I think it was the emergence of a proto-professionalism, a sense of medicine as having this actually common moral purpose. The Dark Ages were dark, probably not as dark as many of us would say historically, but by and large, it wasn't a heyday, let's say, for medicine. But when medicine reemerged in the Middle Ages, it was largely monks who were practicing medicine. The monk herbalist was the physician of the day. They read Hippocrates, they read Galen, they treated people with oaths, with herbs. And they sort of had a sense of medicine, I think, as a spiritual practice. By the late Middle Ages, physicians began to be organized again in guilds, but they also had this sense of purpose. There was if you're familiar with it, a version of the Hippocratic Oath, insofar as a Christian may swear it. Again, this sort of sense that there is a purpose to this, that's a higher calling, something moral. And by the early Renaissance, this began to be incorporated again into the rise of university medical schools. Science became more important to what this enterprise was, particularly through a dissection and the emergence of anatomical pathology. And hospitals were organized very much during this time, as places to treat the sick poor, again, with this sort of deep moral charitable purpose. In the 17th and 19th century, ethics was again at the center of the formal codification of a real sort of sense of professionalism. John Gregory's lectures on ethics from 1772, Thomas Percival in 1803, and really in some ways what got the American Medical Association started, and what made it define itself was its Code of Medical Ethics in 1847. By the early 20th century, then, we mostly had a series of country docs. You may have seen movies about this or old Life magazine photos. University physicians in places like the University of Chicago, private urban practices, and that's the way it was mostly organized in those three spheres. Enormous growth in medical science and technology, but also a growing power for organized medicine. State medical societies became very powerful. The American Medical Association became powerful. And the dominant model of financing was through private practice. Hospitals existed for people who were hospitalized, but they functioned basically as a workshop for doctors. It's the way they were thought of. The organized medical staff basically controlled all the policy decisions, and administrators largely served physicians. And academic medical centers began to emerge, particularly by the late part of the 20th century, with salaried physicians, even from the beginning, as university employees, and not with the sense that this did anything to change their status as members of this profession. And the chiefs of medicine and surgery and other departments were the people who really made all the decisions. I want to take even another step back and just ask, well, if that's the sort of the history of how we've developed this idea of a profession, what is it that makes a profession? And I think one of the best sources for that is Abraham Flexner in actually a little work called Is Social Work a Profession? And he characterizes a profession as being something that's an intellectual activity carried out by individuals for individuals who have a specialized knowledge and a commitment to research, a practical and socially accepted end using specialized techniques and disciplined training that entails membership in a moral community that is self-organizing and self-regulating and tends toward altruism. In some ways, prototypically, that was present for the Hippocratic physicians. Throughout that entire history, I think this began to grow deeper and deeper. But I think it is true of what we think of as why we call medicine a profession. I also want to take another step back, and this will be very challenging, I guess, in the University of Chicago with its economics department, and challenge the idea that we conceive of medicine and medical care itself as a market commodity. In some ways, it may be a part of the fallacy of the generalization of the fall of the Berlin Wall, the fact that a totally state-organized economy fails doesn't mean that everything is simply a commodity in the market or should be treated that way. Because what is provided in healthcare by these professionals, for the most part, you and I, is first and foremost a relationship, a healing relationship that requires the patient to trust that the purpose for that relationship is the good of the individual patient. Even for the economists, they have to recognize that it's hard to fit the round peg into the square hole. Medicine is largely non-fungible, right? People don't generally trade off between, should I spend my money on a vacation to Disney World or get my heart transplant, right? They're not sort of equally balancing those decisions. It's relatively inelastic. When somebody is sick, they say, I don't care what it takes, we'll pay for it, or we'll find some way to do it. There are significant externalities, at least for most viruses. Maybe it wasn't for COVID, but there are kinds of things in medicine that when you treat a certain number of people, lots of things redound to the good of all people. And we generally have thought about healthcare, even in this country, as a social good. It is not owned by individual physicians, right? I don't say when I'm asking somebody in the hospital to volunteer as a patient who will help students with physical diagnosis, can you sort of lend your body for these extra minutes to this student so that he or she can own the knowledge that comes from that and sell it back to your grandchildren at the highest price the market will afford, right? We sort of think of this as being something that we all have a stake in, and people volunteer to be part of that in research and teaching, et cetera. And the remuneration that we have, I think, is most properly thought of as a stipend for a service that is ultimately priceless, right? The life of every individual is actually, in the end, priceless, despite what the economists will say. Our sense of it, at least, is priceless, because the value of the person is priceless. All that said and done, this relationship and the healing that occurs there by professionals is surrounded and supported by markets. There are markets for insurance, for equipment, for drugs and devices. But the central core of it, what we're doing as professionals, I think is wrongly conceived of as a market commodity. And the last sort of general background point I'll make is that the balance of power in a well-ordered, pluralistic, democratic republic requires the relative independence of major institutions. I'm sort of channeling de Tocqueville for those of you who are familiar with it, but for a place like the United States, a pluralistic, liberal, democratic republic to function well, there has to be relative independence and balance of power between the state, the market, the academy, religions, the professions, and other social institutions. And I think we have run consistently into trouble whenever medicine loses its independence in this and becomes an instrument of and totally dominated by either the market or the state or a particular religion, right? That's when we've gotten mostly into trouble. So this idea that medicine is a profession and that the service we provide is really not a market commodity, I think is ultimately at the center of our best traditions. I'll give you some quotes quickly from Hippocrates, Paracelsus, and Osler. Right, Hippocrates even says, again, in this proto-professional sense, sometimes give your services for nothing, calling to mind a previous benefaction or present satisfaction. And if there be an opportunity of serving one who is a stranger in financial straits, give full assistance to all such. For where there is love of man, the word in Greek, philanthropia, there is also love of the art, philotechnia. Paracelsus, never one to mince words, Let no one be astonished that I cannot praise gain in medicine, for since I know how very ruinous profit is, so that the arts are by profit falsified and directed only to appearances and purchase, and that this cannot come to pass without falseness, which falseness causes corruption in all things. And maybe more familiar to you from the early 20th century, Osler. The practice of medicine is an art, not a trade, a calling, and not a business. And I think is the very center of our tradition. How has medicine failed against this ideal? Well, historically, I think there's been a cyclic history of failure and recovery towards that ideal. There are certain points in time when we've been pretty good at this as a profession, and certain times in which we've very much failed it. But there has never been an actual total rejection of the ideal. There have been some people who have not lived up to the ideal, but nobody has said the ideal itself is bad and we shouldn't try to live up against it, live according to it. Still, there are people now saying that the contemporary situation is novel. And they are, I think, arguing for a rejection of the idea of physicians as professionals. And part of that is because of deprofessionalizing forces that are external to the profession of medicine. Common list that you can all probably rehearse, but I'll go through them for you just to get your blood stirring, right? The interests of third-party payers, government or private, the commodification of healthcare. My mentor, Edmund Pellegrino, actually traces it back probably correctly to 1975, in which the Federal Trade Commission banned medicine's previous prohibition of advertising as a restraint on trade. First point at which it's officially the government saying this is a market. And then with our technology leading to inflation, leading to corporations crying out for cost control measures, we entered the era of managed care. We've now developed larger and larger hospital systems, the academic medical centers like this one, Balloon. There are for-profit and non-for-profit systems, and increasing employment of physicians, the use of phrases like service lines for the way in which we used to talk about services, growing public distrust in medicine, even before COVID, and then this sort of growing social idea of the rejection of professionalism, even the ideal of it, as either elitist or hypocritical. If we're honest, the forces that are leading to deprofessionalization are not only external to us, they're internal to us as well. There has been an abuse, I think, of medical power for profit among lots of physicians, particularly beginning in the latter half of the 20th century, in ways that weren't even possible before. Specialization and splintering of our own professional identity. So people don't sort of think of themselves so much as physicians jointly anymore, as a pediatrician or a pediatric nephrologist or a cardiologist or an orthopedic surgeon with practice limited to the left great toe of 5-year-olds, whatever it might be, right? That we're so hyper specialized. A tremendous decline in membership in organized medicine, participation in organized medical staffs, and then a generational shift lately toward more lifestyle considerations. And so that by the 21st century, the increasing bureaucratization of practice made it very difficult to be in private practice, plus the urge for sort of lifestyle considerations, I think, led a lot of physicians to sell their practices or to move out of private practice, so that we're now at the point where the majority of physicians in the US are salaried, slight majority. There's cutthroat competition, as you are very well aware here and any other city, between large healthcare systems. It's the administrators now who hire and fire physicians. And department chairs, typically in most hospitals in the country, report to the administrators. The medical staff is typically organized by the administration. The administrators set the policy. They give incentives for certain financial goals. They set up things like restrictive covenants. Systems are buying up private practices. Investors are buying up practices. Physician administrators, as you're probably well aware, wind up acting like any other administrator in this environment. And it has left physicians, by and large, feeling powerless and dispirited. And I think all of us are aware. I'll call this the sense of deprofessionalization. I think physicians now are feeling the disconnect between the oaths they've sworn to serve patients to what they have professed, their sort of self-identity as professionals, and the social, financial, and administrative structures in which they practice. And the result is that physicians feel thwarted in the effort to be what and maybe who they are, they really identify, and a sort of sense of self-alienation. And I think this is prior to any sort of talk of burnout or anything like that. It's this sort of sense of deprofessionalization and self-alienation. I suspect you'll all agree with me on the problems. What are the possible solutions? Here are at least four. Maybe in the discussion you'll come up with something better, but I think what's on the table right now, we either just limp along with the way we are, which I think is intolerable for most physicians, is increasingly intolerable for patients. We can go concierge, and I won't talk a lot more about that, but I'll just simply say that if everybody goes concierge, then there is no system, right? So it can't be the solution to the problem. Unionization is on the table as the way in which physicians get power back, and the last is what I'll call reprofessionalization. And the rest of the talk, I want to concentrate on why unionization is the wrong solution. Maybe the questions are the right ones, but it's the wrong solution. And in a nutshell, and I'll go through this in more detail, the movement toward unionization, first of all, accepts as a fact deprofessionalization. Just sort of says, we are not professionals, and this is it. We are contracted laborers. The aim of unionization is not justice or the benefit of patients, but power. That's how unions work. It's balancing power between the employer and the employee. I think that the very idea of unionization violates professional ideals and norms. And if we want to continue to think of ourselves as professionals, this violates that. And lastly, I think I'll suggest to you that it probably isn't even going to help in any of the things you thought it was going to help you with in the first place. Unionization punctuates the proletarianization of physicians. And that's what physicians are feeling. I am proletarianized, right? And there's an irony that is at stake in people who are saying, well, we've got to be unionized. We're angry at being treated as laborers rather than professionals, so we'll show you, we'll act like laborers and form a labor union, right? That's not sort of reclaiming the idea of being a professional. Power under the unionization system remains in the hands of the administrators. It doesn't address the root problem, and it violates the tenets of what a profession ought to be as self-regulating and self-organizing. It accepts the domination of medicine by the market and the resultant imbalance of power that becomes problematic, I think, in the very conception of a liberal, pluralistic, democratic republic. It accepts medicine as a market commodity, which I think hits at the heart of what makes medicine, if it is in any way special, something that is produced by physician laborers and sold by medical institutions to consumers. And the issue simply becomes, if unionization is the road we take, how to divide the spoils. There's a lot of money in medicine. Who's going to get it? Who's going to get the power? It treats patients as consumers within this medical industrial complex and just simply accepts all of it. This is not a new idea. It was thought about before. Back in the Hastings Center report, Norman Daniels in 1978 observed that collective bargaining is neither perfect nor imperfect procedural justice. The point is victory, not a correct or a just solution, right? So when you're in these sorts of union positions, that's the way it works. Ed Pellegrino and Arnold Relman in the late 90s in JAMA wrote about professions and unionizations and recognized that what they are, what a union is an economic bargaining instrument. And the primary source of power is the threat of a strike. Don't let anybody ever tell you anything different, right? The only way unions have power is to say, well, we're not going to work anymore. That's the threat, right? And that fear persists even if it's never used. And once that happens, I don't think we're ever going to be able, at least Pellegrino and Relman said, and I would agree, the public view that unionized doctors are going to be self-serving. That unions will be used for working conditions, salary, and benefits, and not, no matter what anybody says, actually centrally for the good of patients. And that all of this, they claimed, undermined the professional ideals of altruism and membership in a moral community. I raised some questions about how effective unions will be. Well, we don't have a lot of data, but one study from a few years ago for unionized versus non-unionized residents, even though lots of residents are joining them, showed no differences in burnout, job satisfaction, salary and benefits, working environment, or duty hours. The unionized residents had one more week of vacation. Is it worth selling the idea of being a professional for one more week of vacation? And is that what you're after, one more week of vacation? So what's the alternative to unionization? The alternative, as I see it, is re-professionalization. An alliance of patients and physicians who latch on still to the idea that the point of the patient-physician relationship is the good of the patient. This is not a market commodity and shouldn't be treated as such. A return to the moral core, the service of the patients. To reinvigorate the role and the authority of the medical staff in hospitals. Now they're typically powerless if people even show up. To reinvigorate organized medicine. Most people aren't part of organized medicine anymore, and so that medicine doesn't speak with any voice and has no power anymore in lobbying, and people know that. People in Washington know that. The insurance companies know that. And the splintering into various groups says that medicine can't act with a unified voice. Everybody's out for themselves, so we ourselves are not coming together in ways that could use our collective power, which is technically what a union is supposed to do, but maybe doesn't, and we can do it in a professional way if we do it, by restoring our, what Cushing called our common devotion. Whether you are a neurosurgeon or a general internist, our common devotion to caring for patients. And that we look to find ways to regulate the markets that support patient care, insurance, equipment, drugs, devices, hospital and practice owners, in such a way that their duties to the shareholders and any other sorts of duties they think will not be satisfied until the duties to patients are fulfilled, because they are, while they are market in a market, serving something that centrally is not part of the market. So you're already probably thinking of some counter arguments, and so I'm going to list some of those and give you some of my rebuttals to those counter arguments, and then we can perhaps you'll have more, but these are the ones that that I've anticipated. The first one that I hear frequently when I talk about this is that unionization for physicians is about patients. It's really not about us. My reply, excuse the French, is get out your bullshit detector. It's not that all the concerns about physician well-being aren't important. They are critically important. But these are the concerns, not the patients, that are the driver, right? During this current Oregon strike, the physician leader Dr. Jennifer Lincoln was quoted just a month and a half ago, saying, as an OB hospitalist, our salaries were cut 12 to 15% in one of the first quarters during COVID. Mind you, they got PPP loan money, and mind you, we never took a shift off. I think the reason you're seeing more unionization is because they see us as just a number, and corporate greed has gotten out of hand. All true, but that's not centrally about patients, right? That's important, but it's not centrally about patients. So I think that that's a false claim. The one that's most common is, this is naive, Dan. Get with the program. You're just engaging in nostalgic professionalism. This is not possible anymore. And I've simply got to say that I would rather stand with Hippocrates, Paracelsus, and Osler than with the AFSCME or the SEIU unions. I can support some of their causes, but I'm not part of those. And I do think that we have the power to re-professionalize, and we simply have not used it. I don't know why we gave it up. We have not used our collective power appropriately. And further, I think it's naive to think that unions are actually going to save medicine. That's the real naivete. It's not sort of thinking that we need to reclaim our position as professionals. It's more naive to think that unions are going to save medicine. Union membership, as you know, is otherwise declining in the US, and doctors, I can tell you, are a growth area for unions. Right? Typically, union dues are 1% of your salary. Maybe graduate students, that's a little bit, but for doctors, that's a lot of money to go after, right? 1%. And if you want to give it up to the union, you can. They have, as I've suggested, essentially not been effective. I don't think they will be, and I guess history will judge us. I've heard people say we can strike without hurting patients. Well, I think the point of a strike is to disrupt patient care. Otherwise, it's not going to be effective, right? That's the bargaining power you have as a union, is say we will strike, and therefore the patients aren't going to are going to be affected in ways that will harm you as administrators. So it is then, in a Kantian sense, using patients merely as a means to physicians' ends. And there have been a couple of studies published that says there's a lack of evidence that increased mortality has been observed during strikes, but I think that's a poor indicator that they are safe or that they are actually good for patients. It's like saying, well, no patients were killed in the filming of this work stoppage, right? Very poor indicator. I've heard people say, well, we can provide coverage to be sure patients are cared for while we're on strike. Well, again, arranging for coverage undermines the power of the strike. So if everybody's still being seen and bills are being paid, then where's the power in that? And it still hurts patients by disrupting continuity of care at the very least. Even if it does nothing else, it's you saying to your patients, I'm not going to see you, but somebody else will cover for me. And the reason is that I'm doing something that is critically necessary, or because my mother died, but it's because I want to get more benefits or more time off or whatever it might be. And that discontinuity in care is sometimes claimed, of course, to be one of the reasons we have to strike, because they're not giving me the chance to have continuity with my patients, which seems, again, ironic. And again, like concierge medicine, it fails the test of universalizability. If everyone were to strike, there would be no one to cover. And that seems to be a problem if you think that it's a moral thing to do. And then the last one, we have no alternative. We are just powerless. But I think there are robust alternatives that simply, it's incredible to me, have not been utilized. One way to go about things is to restore the power of the organized medical staff, which used to run hospitals, used to run all medical institutions. That the medical staff itself needs to reclaim the power to appoint department chairs, which is not the case in most places anymore. Absolutely power in setting clinical policy, which is not the case anymore. There are legal ways to do this. There are legal prohibitions in many states. I don't know about in Illinois on what's called the corporate practice of medicine. And you can use that as a lever legally. Again, that's part of what the idea was of trying to maintain the balance of power between market, state, and profession. And there are alternatives to strikes, right? If you want to get the attention of administrators, tell them we're not going to bill, right? That doesn't hurt patients, right? But it will get the attention of administrators very, very quickly. And you can also do things like picketing, sending letters, writing letters in newspapers, etc. So I just want to leave by asking you, would Hippocrates, Paracelsus, and Osler be calling for unionization? I think not. Maybe you do, and if you do, I'm glad to entertain your thoughts and questions for the rest of the time we have remaining. So thank you.